to all of you. Welcome to the second day of Pancreas 2025. We will start off today's session on research. I call upon the chairpersons for today, Dr. Anugrah Dhuria, Consultant SGPGI Lucknow, Dr. Santosh Kumar, Associate Professor Hepatology CMC Vellore, and Dr. Mahendra Singh Rajput, Consultant Amrita Faridabad.
So good morning everybody, and it's a pleasure to be the opening batsman on the second day. I thank Dr. Sudipto for this opportunity to hear Dr. JP again today. Thank you very much. So my mandate is really survival curve, and to just say a disclaimer, I'm not a statistician, I'm not a biostatistician. I will not be able to teach about survival curves. What I can do is only help students or clinicians understand, utilize, and maybe read, make sense of the data. So with that understanding, maybe let us see in the next 15-20 minutes how to approach survival curves. Now, survival analysis is an extremely versatile and a very commonly used analysis in literature, and people would have encountered that in multiple randomized controlled trials, cohort studies, or time to event analysis. So there are two signatures. One is the event happening, like death or alive, and time to event. So time to death is what is analyzed here in survival analysis. So events can be, as a survival curve indicates, mortality. It could be relapse, or it could be any other adverse events. So if I take a randomized control trial, you have a target population, you are doing a treatment and a control arm and intervening, and then this patient is being followed up till the event happens. These patients can be the events can be either dead, alive, over a period of time. So the time signature is what makes survival analysis important. Similarly, it can be looking at not only death and alive, it could be a target population, whether cured or not cured. So any dichotomous variable which can be cured, not cured. Even in patients with, say, you are looking at acute pancreatitis and you are looking at prevention of necrosis or prevention of infection. So with your intervention, whether the patient was diseased or disease free. So no infection versus infection. So any dichotomous variable. It can be used not only in randomized prospective studies, it can be used in cohort studies, which can be prospective or retrospective, where you can look at exposed and unexposed population, whether they develop a disease or do not develop a disease over a period of time. So essentially, any dichotomous outcome over a period of time can be looked at in survival analysis. Now just to, one of the most important aspect of research is framing a research question, which I think we will hear from Dr. JP. But if I look at what can be answered in this survival analysis, so suppose my question is, what is mortality in acute pancreatitis? So I am looking at death, and my outcome variable in survival analysis will be time to death after initial presentation, which can be either coded in days, weeks, or months. Similarly, it could be readmission after discharge, or comparing development of severe pancreatitis, infected pancreatitis, and then my outcome variable will be development of severe pancreatitis over time. Now in liver patients, we usually use a composite outcome, which is a native liver survival. So liver transplant and death becomes a single event of interest, and we are looking at an outcome variable of transplant-free survival, or time to death or transplant after the start of the syndrome. Now, how is it different from the usual analysis that we do, a linear regression or a logistic regression? In logistic regression, we use dichotomous variable, but we do not have the time component. You can only have death, alive, but we lose the time component in that. In linear regression, if I put time to event as a linear dependent outcome, it ignores censoring. So censoring is a very powerful tool in this survival analysis. Just to spend a bit of a time here, in censoring, what happens is any real-time data or any real-time trials will have to have a time period defined. So you can't keep on following this patient up unlimitedly. All people will eventually die, but we will have to limit our time. So almost all trials and all prospective studies will be right censored, where you say, I will follow this patient up for a period of 1 year, 5 years, and beyond 1 year, 5 years, I do not use the data for that patient. So this is a right censoring means the patients who do not have an outcome of interest during the follow-up period. Now this could be because of the termination of study, as is the case with any follow-up study. It could be death due to any other cause, so which may not be the outcome of interest for us, and it could be more realistically a loss to follow-up patient as well. So all of this is right censored. Now the advantage of right censoring, when you are doing loss, if there is a loss to follow-up, the period of the patient who during the time he was in the study period, he was alive, we use that data as well. So that is the strength of the survival analysis, using the data of the patient, of that patient, even after loss to follow-up, during the period he was in the study. So he may be, so maybe we'll go with examples in the following slides. Now, how to analyze this survival curve or survival analysis? The most commonly used is Kaplan-Meier survival curve. I will deal only with Kaplan-Meier survival curve. It is a non-parametric estimate. Not many assumptions are required, very robust, and it basically takes into account empirical probability of surviving past a certain time, provided you reach that certain time. So it has both the components. It is cumulative survival, and expected time to event is 1 upon the incidence rate. How do you code the data here? If for the scholars here, if I am looking at acute pancreatitis, say, and intervention and acute pancreatitis control, I have to make sure I can code the group to which these patients belong, treatment or placebo. I need to know whether they had the event of interest, which could be death. So I have said death, or did not have the event of, or where I can say censored, and what is the survival time that I know of. So if there is a death, what is the date, what is the time at which the death happened, or if the censored, what is the follow-up period that the patient had on the study. So this is the standard control trial design, wherein just a hypothetical, say 5 patients at the start of the study receive an intervention and followed up over a time in months over to the end of the study. This is a standard control trial design. Now, if I start at this point, it may be the recruitment will happen over the 3 months or 6 months or whatever time period, but for the survival analysis, it is assumed that all patients are recruited at a single line. So if I start at this point, now after a follow-up, after the intervention, the follow-up of 4 months, subject E dies at 4 months. So how do we look at it? The survival curve is now plotted here. Now till 4 months of time period, all 5 patients were followed up, and we have data, all 5 patients after the intervention were alive. So till the period of 4 months, there is 100% survival. But at 4th month, there is 1 patient who dies. So, and there are 5 patients on the in the denominator. So the fraction surviving at this point will be 4 out of 5. So the Kaplan-Meier curve is a misnomer. It is a step downwards. It is always going downwards. It's always a step, not and each step is one event happening. Now, when we continue to follow up this group of patients, at 6 months, we lose to follow up 1 patient, and at 7 months, 1 more patient dies. Now, how do the curve or how do the survival analysis take it into account? Now, you can see at 6 months that the patient has dropped or follow-up was lost. This is called the censored patient. There is no event. The data was used before this in the denominator, and that is the strength of the censorship. This is usually the way the censored patients are depicted, and when at 7th month 1 more patient who dies is then at this point at 7th month there are only 3 patients on follow-up. So one had expired already, one is censored, so and out of the 3 patients, now the second patient has died. So 2 out of 3 mortality. So this is the proportion at various time points, and if we say the other 2 patients actually survived the entire period of observation. Now the problem with always of any right censored data is, after the end of the study, say next day the patient expires, we do not take care, we cannot account for that occurrence. We may have to write in statistics in text, but we can't take it into the study. So if these 2 patients survive the study period, then what is the probability? So probability, these 2 patients then remain follow-up alive at that point of time. So what is the probability of survival, which is a cumulative survival probability of at point A and B, which is a multiplication of probability at point A and probability at point B. So the overall survival will then look at 4 by 5 into 2 by 3.53. So it's always a step down. It is a unidirectional curve, and it takes into account the previous survival and it builds on that data. Now limitations of survival curve are it's mainly descriptive. It doesn't control for covariates, so it is only looking at one single and you can look at categorical variable, one categorical predictor. We will look at that. So it requires categorical predictors. It is always difficult. We are assuming that a patient has death alive. The patient may have, say, recurrent acute pancreatitis. And if there is one episode of pancreatitis, this patient may again repeatedly have acute pancreatitis. Now this Kaplan-Meier analysis in this format will not be able to look at repeated episodes of acute pancreatitis. Now I'm going to change track, and I'm going to look at organ which is a sort of conical organ next to the pancreas. So for people who have forgotten, it's the liver. And I'm going to look at a disease which is a bit more closer to my heart, is non-cirrhotic intrahepatic portal hypertension. Non-cirrhotic intrahepatic portal hypertension is a chronic liver disorder affecting the small portal vein radicals with a natural history spanning 15 to 20 to 30 years, and so a long follow-up period. It is a difficult disease to diagnose, and it has gone through various terminology changes over time. And the recent from Europe, I think the terminology they prefer is portosinusoidal vascular disorder, though the Asia Pacific still likes to call it non-cirrhotic portal fibrosis. So in NCI-PH, it's an uncommon disease for the world, but it is an Indian disease. So in India, you still have quite a few of these patients, and we are one of the bigger centers for non-cirrhotic portal hypertension. I think we will have the world's largest cohort of non-cirrhotic portal hypertension patients on follow-up. So the questions, any survival analysis or any analysis starts with the questions. So what are the questions that we can answer? So we asked 3 questions here. What is the risk of adverse outcome? So adverse outcomes we defined as mortality, any decompensation of liver disease or portal vein thrombosis in a patient with non-cirrhotic portal hypertension. Second question that we asked was, does the usual staging of cirrhosis apply to patients with non-cirrhotic portal hypertension? So does the usual staging apply and predict adverse outcome in these patients? And do we have any other factors determining the risk of adverse outcome? So for survival analysis, the first is the starting point to be defined. Now for randomized control trial, it's easy. When you intervene at the time of intervention, that is the starting point. But for a cohort study, you will have to define the starting point. So we define the starting point as the biopsy diagnosis of non-cirrhotic portal hypertension. So these patients would be maybe symptomatic beforehand. So maybe we had a delay in diagnosis of 1 to 2 years in these patients, and they had symptoms prior to that. But we didn't include that time period for our analysis, and that may be a part of, we can say, left censoring of events before that, before this diagnosis was considered. Now again, the period of recruitment, as I said, was over a period of time, 1996 to 2017. But when you analyze, you always analyze as a single starting point for all these patients. The treatment may have changed over a long period of time, the prognosis may have changed over a long period of time, but the analysis limitation is it will start at a single line. Now, for defining the starting point, one is definitely what is the starting, what point you are starting, but of course the patient characteristics at the point of starting. So you have to define what is the patient characteristics. That is the randomized, in any RCT you have baseline characters in patients and they have to be matched in the two groups. Now, as I said, over the time we had recruited a lot of patients, and the second point to be defined is the time period. Now, for us it was a retrospective cohort study, so not much we didn't have to define. We kept on going for the time period as much as the follow-up required, and at the time of writing up the manuscript. But for randomized control trial, we'll have to define a time period, and for us the follow-up was around 76 months. But it is very evident that as the time increases, the events start to accrue. So if the two groups do not match in the time period, when you are comparing them, then the problem will happen in the analysis as well. Follow-up, we had follow-up of more than 5 years, and as I said, predefined endpoint and right censoring is a reality in most of the prospective studies. Now, third point is to have to define the outcome of interest. For us, it was new onset decompensation, new onset portal vein thrombosis, and a terminal outcome, which we said with death and liver transplant as together. Always, it's a good idea to say how many number of events have accrued over the time period so that we realize what is the numbers that we are dealing with. Now, you can depict the Kaplan-Meier curve as incidence or survival. I have depicted it as incidence over time period, and so it keeps on increasing. I have depicted the three outcomes: portal vein thrombosis, decompensation, and terminal, and you can see it keeps on increasing over time. But as it is a chronic disorder, you will see only 16-17% over a period of 5-year period. So it's only slowly increasing over time. It's a one-way graph, unidirectional graph, which is increasing over time. The table below is the numbers at risk. So this is one way of depiction. You are saying 1-year survival, 2-year, 3-year, 5-year survival. The other metric is a median survival, which is at time where there is a 50% people who are in the trial or in the study surviving. So that is a metric which is most commonly employed, but I couldn't employ in this patient because none of them reach 50% outcome. The other table below is the numbers at risk, which is a very important table to know, which gives us how many people were there at that time point to calculate the survival at that time point. So that this will tell you how robust is your analysis. So this is always to be reported when you are doing it in your study. And you can see towards the end of the study, that is at 5-year, 10-year period, we had much lesser numbers than we started at. We started at 172, but the patients started, we lost to follow up quite a few of these patients. So the robustness of the study or the robustness of the figures will be much lesser towards the right hand of the curve. The second objective was whether the staging of the cirrhosis predicts outcome in these patients with non-cirrhotic portal hypertension. And you looked at 1-year and 5-year survival in various stages, and we draw a Kaplan-Meier curve for all the stages. We had only 2, 3, and 4 stages, and we compared survival across the group, severity group. The survival across the severity group can be easily compared by log rank test. I am not going to detail about this. It's a chi-square based test, difference between observed and expected, and it will give you, and this, if the curves are intersecting each other, just to make a point, if the curves intersect each other, usually they are not significantly different. The other thing that you can look at in the curve is when do the events happen. So you can see there are a lot of people who are being censored, the vertical line, and the steps, you can see the step downs are starting to happen only at 10 to 15 years of follow-up. So essentially what it means is the Kaplan-Meier curve gives you a pictorial representation of how many events and when do they occur in the life cycle. Now, its third objective was to compare whether there are any predictors or confounders for outcome of interest, and we looked at overall survival, decompensation-free survival, and portal vein thrombosis-free survival. The test to use is Cox proportional hazards model. I'm not going to detail, I'm not qualified for that. But you can look at various parameters. I have done only univariate because my event size was very small. But we can do a multivariate provided you have enough events to look at it. You can look at even continuous variables like what we put as hepatic venous portal gradient, which is a continuous variable, and definitely you can look at, say, hematemesis yes or no. So categorical variable as in Kaplan-Meier curve. So Cox proportional hazards regression model is a semi-parametric. Again, it gives you a hazard ratio. As you can see, hazard ratio and a p-value, but hazard ratio doesn't sort of assume any baseline hazard. It just compares between the two groups, and it can study various predictors and covariates. So it estimates a relative rather than an absolute risk. So to conclude here, the Kaplan-Meier survival analysis generally is easy. We have used a few times, and it is versatile time to event analysis. We have to look out for numbers at risk to see how robust is the analysis. Follow-up period is important to report, and overall event size, how many events are we reporting, is something which is important. Cox regression can be used to adjust for potential confounders. What I haven't discussed and which is more complicated is how do we deal with time-dependent variables, how do we deal with competing risks, and how do we deal with repeated events. So thank you.